Hi, I'm Ed Shahady, and we're here at the Cardiometabolic Risk Summit in Las Vegas. And I'm here with Dr. Jeffery Levine. Jeff is a professor at Robert Wood Johnson School of Medicine. And he's going to be talking later about contraceptive issues in women who have cardiometabolic risk. What are you going to be talking about?
Well, basically, I want to make sure everyone is aware, and I'm sure they are in their practice, that unintended pregnancy is still a major public health issue in this country. Even with significant reductions, still about 45% of pregnancies in this country are unintended. And regardless of what your political views are, about half of those result in elective abortion. And there's a big push to try to help reduce that, and using what's called long-acting reversible contraception, IUDs and implants. The problem is that patients who are at the highest risk for both morbidity and mortality, not only the mother but the fetus itself, are the very patients who often are not offered these methods. And that includes patients with cardiometabolic risk factors such as diabetes, hypertension, and hypercoagulable disorders. Because there's perpetuated myths that we do know that estrogens are prothrombotic and can increase certain VTE and also cardiovascular risk in those high-risk patients. But that's not true for progestins, and for some reason that has been perpetuated that all hormones are unsafe in these.
But don't progestins influence the cholesterol level, the LDL level, HDL level?
But these, particularly, let's say the levonorgestrel IUD, it really acts locally, so it has almost no systemic effect. And even the implant has been studied in patients on statins and diabetics, has not been found to have any adverse cardiovascular effects. But nothing puts you at higher risk for cardiovascular events than pregnancy.
So if you have choices that don't influence negatively, because if they do have hyperlipidemia, I'm thinking of, say, a woman with familial hypercholesterolemia. I have a couple of those in my practice. So I want to choose a contraceptive, or offer them a contraceptive. Which is the one you suggest using in there?
Well, estrogens can increase HDL. The problem is there's no evidence that that translates into lower cardiovascular risk. But they certainly can increase cardiovascular VTE, on the venous side, VTE, events and stroke and heart attack, particularly in older patients and patients who have other risk factors. But the levonorgestrel IUD, the progestin implant, and the copper IUD, which has no hormones, are all considered safe. And there's actually very good evidence that I'm going to present to support that, because who am I? I'm a guy from Jersey. I'm going to trust everybody from Jersey. So I'm going to back it up with the evidence to show that not only is this safe and effective, but actually to try to help get participants to put it into practice.
Anything else relative to contraception we should be concerned about?
I think that asking the question. I think people just think, well, I don't see patients for the gynecologic care. It's not something to ask. All primary care providers should be talking to their reproductive age women about pregnancy intention, getting comfortable with that. And if you have a patient who doesn't want to get pregnant within the next year, and for whom pregnancy would have a significant negative impact on their quality of life, then that's something you should at least be discussed with them. And if you don't feel comfortable using these devices, at least don't perpetuate myths that have been perpetuated by clinicians, not just lay people. And I think that makes you a more well-rounded clinician, and I think it makes you more patient-centered for women.
And women, the data shows, they'll have a baby and they don't go back to the OB-GYN, they go back to the primary care.
Absolutely.
And so we got to be on top of it. Like some of them were pre-diabetic or had gestational diabetes. It's our responsibility as primary care to follow them up.
Actually, if you guys go back to our previous talks, we actually talked about that. About women with gestational diabetes don't go back and get retested and rechecked. And they have almost a 10-fold increase versus developing diabetes. So there's so many reasons that we need to take a sexual history and an obstetrical history in these patients, because not only to prepare them when they do want to get pregnant for a safe outcome, especially if they have cardiometabolic risk, but if they're not at that time in their life, to help prevent an unintended pregnancy and the extra risks that go along with someone with diabetes, hypertension, or thromboembolic.
I would think those female patients that are later on, maybe they're in their early 40s that don't think they can get pregnant, are also some of the ones that get pregnant.
The second highest rate of unintended pregnancies are women over 40 because they miss a few periods. They say, oh, I must be going through the changes.
Yes.
And their partner, new partner, they might be divorced, widowed, and they have a new partner who's older, and for whatever reason they can't use barrier methods, and they say, well, I don't need to use anything, and then they think they're going through changes in what they really are pregnant. And I can't tell you personally how many of these women that I deal with, and because nobody really addresses this as an issue in our younger patients as well as our more mature women.
I like it more mature.
Oh, trust me, I've learned my lesson.
Very good. Well, thank you very much.
All right, thank you so much.
Very educated.